Good day to everyone. I am going to continue with my lecture on anemias and approach in their diagnosis. This is part 3 and I am Dr. Christian Dominic Rosales. I'm going to begin now my discussion with the classification of anemia based on the underlying mechanisms. The first mechanism that I'm going to discuss is about acute or chronic blood loss. Now, blood loss can be considered as acute or chronic. In acute post-hemorrhagic anemia, when larger amounts of blood are lost over shorter periods of time, anemia may eventually develop, although iron stores remain adequate. The morphology of the anemia in this kind of condition are often normochromic and normocytic with a normal MCV and MCHC. Up to 20% or approximately 500 to 1000 ml of blood may be lost without clinical signs at rest, but with mild exercise, the patient may experience tachycardia or a rapid heartbeat. Meanwhile, in chronic post-hemorrhagic anemia, when the rate of loss exceeds the regenerative capacity of the bone marrow, or when the iron reserves are severely depleted, iron deficiency anemia may now appear. The second mechanism that I'm going to describe is about hemolysis. Anemias of this kind often demonstrate the following features. First, a shortened red cell lifespan below the normal 120 days. Also, there's elevated erythropoietin levels and a compensatory rise in erythropoiesis. And likewise, there's also an accumulation of hemoglobin degradation products. It may be an intrinsic hemolytic anemia wherein there's a defect of the red blood cell itself, which are frequently hereditary and typically categorized as a membrane, metabolic, or hemoglobin defects. Also, it can be an extrinsic hemolytic anemia wherein the factor is outside the red blood cell itself and just acting upon it, which are almost always acquired. If the destruction is intravascular and the quantity of destroyed or hemolyzed blood is substantial, free hemoglobin and methylmalbumin will be present in the plasma, in states such as hemoglobinemia and methylmalbuminemia. The urine may harbor free hemoglobin and also hemosiderin. If the hemolysis is principally extravascular, no hemoglobinemia, hemoglobinuria, or hemosideruria should be around or present. And it is noteworthy that hemolysis is detected by measuring an increase or a rise in one of the byproducts of heme catabolism, such as carbon monoxide, an indirect serum bilirubin, and urine or fecal urobilinogen. Inherited hemolytic anemia can present either as a membrane defect, as a metabolic disorder, abnormal globin defects, or probably in the form of a deficient globin synthesis. An example of a membrane defect will be in condition called as hereditary spherocytosis. For metabolic disorders, an example of that would be glucose 6-phosphate dehydrogenase deficiency or a G6PD deficiency. Another example will be the pyrimidine 5' nucleotidase deficiency, where it is often characterized by the observance of stippling among red blood cells. A common representation of abnormal globin defects will be the sickle cell anemia. And finally, an example of a deficient global synthesis will be a condition called as thalassemia. Now I'm going to discuss about hereditary spherocytosis. This condition is common among individuals who have a Northern European ancestry. It is the most common disease affecting the red cell membrane, and red blood cells of this condition often present as small, mechanically fragile, and spheroidal cells. The spherocytes, as the condition implies, appear microcytic, and they often demonstrate an abnormal osmotic fragility. This osmotic fragility test is a test that measures the in vitro lysis of erythrocytes suspended in solutions of decreasing osmolarity. Spherocytes are characterized by membrane loss and less redundancy to withstand decreasing osmolarity. The inheritance pattern of this condition is primarily autosomal dominant in 75% of cases. Mutations in various structural membrane proteins are evident, and parvovirus is known to cause this transient cessation of erythropoiesis and the development of severe anemia under the circumstances is termed aplastic crisis. Here is a peripheral blood smear picture of a patient suffering from hereditary spherocytosis. The black arrows there point to the spherocytes, which are spheroidal cells who have lacked a central pallor. If you're going to direct your attention to the right side of the slide, you can see two rows of test tubes. The top row will correspond to the control, and the row at the bottom will be the test samples. When red blood cells become more fragile, hemolysis may begin at about 0.85% saline and be complete at about 0.58% saline, which is evident at the lower row. Meanwhile, when red blood cells are less fragile, hemolysis starts at 66% and is complete at lower strength, about 38% of saline, which is evident if you look at the upper row of tubes. Now moving on to the glucose 6-phosphate dehydrogenase deficiency. It is an inherited X-linked disorder, and because G6PD deficiency is determined by a gene on the X chromosome, full expression of the deficiency is found in the male hemizygote. It is a condition characterized by deficiencies of enzymes in the anaerobic pathway, particularly the pentose phosphate pathway. This condition happens in 10 to 14% of African Americans, and the defect is fairly harmless unless one is exposed to certain drugs such as primaquine and sulfonamides. Reticulocytosis begins at about the fifth day and reaches maximum in 10 to 20 days. Heinz bodies and increased serum bilirubin happen during the first few days of hemolysis. Another variety of G6PD deficiency is particularly common in persons having a Mediterranean descent. Sickle cell anemia is a blood disorder almost exclusively in people of African descent. One of every 600 black persons in the United States suffers from it. It is a form of hemoglobin disorder, exemplified by hemoglobin S. In hemoglobin S, the glutamic acid in the sixth position on the beta chain is replaced by valine. Hemoglobin S is freely soluble when fully oxygenated. When oxygen is removed, hemoglobin S polymerizes with the formation of tactoids, or basically fluid crystals, that are rigid and deform the cell into the shape that gave the cell its name. It is characterized by severe chronic anemia, punctuated by painful crises, the latter due to the blockage of the capillary beds in multiple organs by masses of sickled red cells. In homozygous disease, or HBSS, sickling occurs at physiologic oxygen tension. The spleen is a major organ playing host to three complications. First, sequestration crisis. Second, functional asplenia. And third, autosplenectomy. Other serious complications of this condition would include vaso-occlusive crisis, aplastic crisis, and hemolytic crisis. The diagnosis is suggested by the clinical findings and the presence of irreversibly sickled red cells, and is confirmed by multiple tests for sickle hemoglobin, most especially hemoglobin electrophoresis. Here is a graphic illustration of an hemoglobin electrophoresis. There is electrophoretic separation of hemoglobins at alkaline pH. There are 7 lanes in this slide. Lane 1 indicates a normal adult. Lanes 2 and 3 shows a 17-year-old patient with a sickle cell anemia, or HBSS. This is proven by a dark band, a line at the S level. Lanes 5 and 6 shows a patient with sickle cell anemia who has been recently transfused. Note the presence of hemoglobin A from the transfused red blood cells, but there is still a faint or a less conspicuous band noted at the S level. That's all for part 3. Please proceed to part 4. Till then, thanks for watching.